Right. Start. Good morning, everybody. Today we are going to discuss about poliomyelitis and cerebral palsy. So first, poliomyelitis. So what is poliomyelitis? It is an infectious disease which is caused by an enteric virus, and it commonly affects the anterior horn cells of the spinal cord. They are affected. And coming to the etiology, it is caused by neurotropic virus, which has affinity for the neurons in the anterior horn of spinal cord and the motor nuclei in the brain. So whenever this condition persists, there is a hypothesis that this paralysis may be precipitated after strenuous activity or after an intramuscular injection or a child on cortisone therapy who is immunocompromised. And sometimes during the epidemics, if the tonsillectomy, adenoidectomy, or tooth extraction also, they predispose to paralysis. So coming to the pathology, most commonly anterior horn cells of the spinal cord are affected. So usually motor component will be affected. Motor component of the muscles will be affected. Usually there are no changes in the sensory as well as bowel and bladder control. Coming to the pathological changes, you have edema and chromatolysis of the motor neuron cells in the anterior horn. And the first change is the chromatolysis of the Nissl substance in the cytoplasm. So whichever anterior horn cells are affected, the corresponding muscles are paralyzed. Since anterior horn cells are affected, it will be a lower motor neuron type of paralysis. So this is mainly about the pathology. And coming to the clinical features, the disease, it occurs in few stages. In the acute stage, you have the pre-paralytic stage, followed by paralytic stage, then convalescent stage, and then stage of recovery or residual paralysis will be there. So in the pre-paralytic stage, what we will find, it may vary right from simple fever and meningitis symptoms to paralysis will occur in the acute stage. In the acute stage, you will have the signs of meningitis to that of acute onset of paralysis will also be there. So early symptoms are fever, headache, and other prodromal symptoms like sore throat. And there will be sudden onset of neck stiffness, irritability, nausea, and vomiting, resembling features like meningitis. And there will be severe aching and spasm of the back muscles. And the involved muscles, there will be marked tenderness. Because of the marked tenderness, there will be spasm of the muscles. And the patient usually tries to lie down in a curled position, position of ease to counter the spasm of because of the spasm of the muscles and tenderness of the muscles. So there will be flexion at hip joint, knee joint, and other joints, and the patient will lie down in a curled position. So this is the feature of pre-paralytic phase, which is a part of acute stage. Suppose without onset of paralysis, if the disease recovers from this point, it is called non-paralytic poliomyelitis. So coming to the paralytic poliomyelitis, there will be a sudden onset of flaccid because of lower motor neuron type. You will have flaccid type and asymmetrical paralysis. One side of the body or asymmetric muscle involvement will be there depending on the involvement of the anterior horn cells which are affected. So there will be asymmetrical paralysis of the muscles of the limb and trunk. It usually occurs, this paralytic phase starts after 2 to 3 days after the onset of the fever. And as I told earlier, there will not be any sensory loss and bowel and bladder involvement is also not seen. And in poliomyelitis, there are two types of poliomyelitis. One is spinal form and the other one is the bulbar form. In spinal form, because the anterior horn cells are involved, the lower motor neuron is involved, there will be flaccid paralysis. And then the most common muscles which are involved are tibialis anterior, posterior, quadriceps. Gluteal muscles are most commonly involved. Quadriceps is the most commonly involved muscle, and tibialis anterior is the muscle which is completely paralyzed because this muscle has lesser columns involved. So tibialis anterior, if it is affected, it is completely lost. And coming to the bulbar form, the cranial nerves are most commonly affected. So as a result, the first symptom will be nasal intonation and there will be gradual respiratory obstruction in majority of the cases. And during this time, we should be very careful. Signs of respiratory paralysis should also be watched for, because in this phase, if respiratory paralysis occurs and if the patient is managed through this phase successfully, then uh, there will be recovery. If it is not attended to, it may prove fatal. So one should be watchful about the respiratory muscle paralysis. So what are the different features? Usually diaphragm is involved, phrenic nerve is involved, C3, C4, etc. So there may be some paralysis or difficulty in abducting the shoulder, or paralysis of the deltoid muscle will be seen. So these are some of the features which we have to be watchful. If that group of muscle is involved, one should be extremely careful about the respiratory paralysis, whether there is any increased respiratory rate or accessory muscles being involved. All these things should be observed. And coming to the recovery stage or convalescent stage, once the maximum point of paralysis is reached, then the muscles gradually recover. And usually, if any muscle fails to regain its original power within 3 months, the chances of recovery are meager. So most of the recovery it is seen in 3 to 6 months. And this recovery process may last up to 2 years. So that is the recovery stage or convalescent stage. And coming to the residual paralysis stage, it is the term which is used to indicate the residual paralysis, that is the muscles which have not regained their function after 2 years of onset of the disease. So that is the residual paralysis, post-polio residual paralysis. Even after 2 years of onset of the disease, whichever group of muscles are paralyzed, that status is called residual paralysis stage. So at this stage, what are the challenges which we face? They are deformities, disuse atrophy of muscles, and shortening of the leg. And one more thing is, if a child later the onset of the disease, higher is the age of the child, more severe will be the disease, and there will be increased extent of residual paralysis. Earlier, if the age of onset is early, the prognosis will be good. If the disease onset is late, then the extent of disease will be more, and the extent of residual paralysis will also be more. That is one thing we have to keep in mind. So coming to the residual paralysis, deformities. See, one group of muscle, usually what happens, as I told, there will be asymmetrical paralysis and some group of anterior muscles are involved. So when one group of muscles are involved and the other group is actively working, the antagonist group is active, then what happens? There will be excess pull of the joint because of the antagonizing group of muscles. Suppose if there is knee joint is you take knee joint as example. If the quadriceps is weakened or paralyzed and there will be excess action of hamstrings, what will happen? The knee will go into contraction gradually. Suppose if it is not attended to, what will happen? Then that deformity will get fixed. So that is the main reason for, that is one of the major challenges. So we have to prevent the occurrence of deformities. And then because there is no nerve supply to the muscles and the muscles are not kept under usage, there will be disuse atrophy of the muscles. These are two things. And third thing is, for any bone to grow, there should be muscular covered blood supply, nerve supply, because the remodeling of the bone occurs with the help of the muscular attachments and muscular activities. So one thing, there will be thinning of the bone, and then shortening of the bone will also be there because the diminished muscular activity. There will be some shortening of the leg because of the decreased blood supply and other things at the fascial region. There will be shortening of the leg. So these are the three things which are to be addressed during residual paralysis stage. So here once again, coming to the stages of poliomyelitis. Initially following the incubation period, then we have the pre-paralytic stage where the features are similar to that of meningitis, and then slowly the muscles, they get involved one by one serially. Suppose before the involvement of muscles, before the paralysis of muscle occurs, if the disease subsides, that is called non-paralytic poliomyelitis. And once at the C, you can, at this point of C, you can see that there is stage of maximal paralysis. And after that, there is stage of recovery where each muscle group will be recovering gradually. So after that, a group of muscle, they will remain as it is. They will not recover. So that status is called post-polio residual paralysis. So this is all about different stages of poliomyelitis. So this post-polio residual paralysis is given as a question in your university examination. Otherwise, there are not many questions from this topic, but post-polio residual paralysis was once given as an essay question in public examination. So when such question comes, you should be in a position to answer. So please pay attention to it. And coming to the abortive poliomyelitis, it is usually recognized during an epidemic. Usually there will be some non-specific symptoms like headache, vomiting and drowsiness, and the diagnosis is proved by CSF changes during the convalescent stage. So this is abortive poliomyelitis. And few important points which I would like to emphasize are, one thing, these are important for your entrance point of view also. So in poliomyelitis, lower limbs are most commonly involved than upper limbs, and quadriceps is the muscle which is most commonly involved. And as I told earlier, tibialis anterior undergoes complete paralysis. In the hand, usually though in the upper limb, the involvement of hand is less. Coming to the hand itself, opponent's pollicis is the most commonly involved muscle. Whereas in the upper limb, usually shoulder and elbow are most commonly involved and hand muscles are spared. If at all hand is involved, opponent's pollicis is the most commonly involved muscle. In 10% of patients, there will be involvement of respiratory muscles. Because of the respiratory paralysis, the prognosis is fatal. Usually, the earliest reflexes, superficial reflexes, are the first reflexes to disappear because it is a lower motor neuron type of condition. So, whenever we have a child who is affected by polio, 30% of the children, they recover completely in first weeks or months, and 30% of the children, they have mild paralysis, and 30% will have moderate to severe paralysis. That is that they are ambulatory, they ambulate using some crutches or assistive devices or wheelchair bound, and some 10% of children who get affected by respiratory paralysis often die because of respiratory problems as well as difficulty in swallowing, aspiration, etc. And the muscles which are most commonly involved are shoulder muscles. You have shoulder muscles involved, and then because lower limb is most commonly involved, these muscles, quadriceps, tibialis anterior, they will be involved. See, there will be some contractures at the knee joint. I am showing it with the cursor. This is the equinus deformity. Equinus deformity means plantar flexion deformity at the ankle. Even there you can see that there is diffuse wasting of the muscles. And whenever there is some muscular imbalance, what will happen in the spinal muscles? One group of muscles will be acting and the other group is paralyzed. So gradually the spine will be deviated to one side, leading to other deformities like scoliosis. So these are the things which you have to remember. So coming to the management of poliomyelitis. So in acute stage, there will be severe muscle spasm, fever, and meningeal irritation, neck stiffness, etc. So during this period, supportive symptomatic treatment is given. And coming to the muscular spasms, there will be some water baths, whirlpool or Hubbard baths, they are present. I will show you the picture. In the warm water, the child is kept, and gradually passive range of motion exercises are done by the physiotherapist or whoever is taking care of the child. So there will be soothing effect on the muscles which are under spasm. So that is one thing which is done to relieve the spasm. And second thing is the if at all during that phase, plaster splints are used, and then the patient is placed in functional position. So even though some deformity occurs, it will occur in a position in which the limb can be kept to use. So in such position, I think you have understood what functional position is. Even though some deformity occurs, if that deformity occurs in the functional position, the child will be in a position to use the limb in some manner possible, or the patient. So that is the functional position, and less position in which the patient will have less discomfort. In that position, the patient should be placed, and preferably some planks should be placed beneath the mattress. There should not be any slouching, or some slouched position should be avoided. So that is one thing which we have to take care in acute stage. And then, as I told earlier, one should be very much watchful about the respiratory paralysis. So if at all there is onset of respiratory paralysis, either respirators or respiratory support, or if necessary, tracheostomy can be done in the acute stages. And then because if at all there is bulbar involvement, there will be some aspiration and other things, and secondary respiratory tract infections will also be there. So all these things should be prevented and addressed. And coming to the orthopedic point of view, this plaster splints, placing the limbs in functional position, these things we have to attend to. And coming to the recovery stage, slowly these paralyzed muscles will be recovering. So one has to aid to the recovery by making them do some remedial exercises, hydrotherapy, as I told, in the Hubbard bath, and some whirlpools will be there. In that the patient will be placed, and slow range of motion exercises. First, passive movements. That is, the doctor himself, the doctor or physiotherapist himself does the movements of the joint. Then assisted movements, that there will be some voluntary participation of the patient will be there, and the doctor will be assisting in the motion which is being done. And then gradually the exercises are increased, those remedial exercises will be done, and a certain group of muscles, they will be paralyzed and one group will be acting. So in such cases, these orthoses are used to support the limb and to prevent the occurrence of deformities, like AFO, ankle foot orthosis, and other things are used. And serially, the muscles, the power of the muscles should be assessed using MRC grading. You have this MRC grading. I think one of you can tell at least few grades. I think one of you can tell. Do you know whether MRC grading or not? Come on, somebody reply in the chat box. MRC grading in nervous system examination: 0 no contracture, 1 flicker of contraction, 5 full power. You remember the grading? Have you ever heard of it? Somebody reply no. So before I finish this session, somebody reply whether you know MRC grading or not, or a few points. Please type in the chat box. So serially, the muscles are graded using MRC grading to see if the muscle has recovered or not. So that is the recovery stage. And after that, you have the residual paralysis. As I told, after 2 years, after occurrence of the disease, whichever group of muscles are paralyzed, and that is the status of the residual paralysis. The group of muscles which are paralyzed after 2 years contribute to the post-polio residual paralysis. So in that situation, we have to correct the established deformities and improve the muscular balance, and the joints should be stabilized. If there are any flail joints, they should be stabilized. So these are all the different challenges which we should face in residual paralysis. So when you are given a question of post-polio residual paralysis, you have to write the definition of post-polio residual paralysis and then different challenges which we are going to face and the treatment for the corresponding challenges. So as I discussed earlier, in case of respiratory involvement, please watch for signs of bulbar palsy or respiratory muscle involvement. In this condition, usually to relieve the muscle spasms, ordinarily some sedatives will be given, but in this condition you should not give sedatives because they will contribute to the respiratory depression. So you should not give sedatives in this condition. Treadlenberg position, that is head down position, should be preferred because there will be some push of the abdominal contents on the diaphragm, and as a result the respiratory drive may be stimulated. And in this condition, if necessary, respiratory paralysis is seen. Tracheostomy, endotracheal intubation and use of respirators can be used. So coming to the orthopedic management, as I told earlier, positioning in the functional position, then relaxing of the paralyzed muscle and stretching of the spastic muscles should be done. And board should be kept beneath the mattress to prevent the slouching position. So to be more clear, suppose no boards are kept under the mattress, the patient may bend like that at the back. Suppose a firm board is present, the patient will also sleep without any slouched position. I hope I am clear about the slouched position. And then at the footboard also, a padded footboard should be kept. That is at foot end. Suppose this is the couch and you have the footboard here, so that the foot will be kept in neutral position. Suppose the footboard is not kept padded, if the footboard is not padded, there will be pressure source. So there should be a padded footboard. If footboard is not kept, gradually because of the gravity, the foot will fall into the equinus position. So to prevent the equinus contracture, a padded footboard should be present. And different positions which are to be maintained are hip should be maintained in abduction and neutral rotation, and then knees should be maintained with slight flexion with some rolls beneath the knee joint. Otherwise what will happen, because there will be genu recurvatum will be occurring and posterior subluxation of tibia etc. will be occurring. So to prevent that, a roll is kept beneath the knee and knee is kept in slight 15 to 20 degrees of flexion. And then the ankle, as I told earlier, will be kept in neutral position. So coming to the surgical management. Principles of surgical management, one thing is restoration of muscle balance. Suppose there is a equinus deformity of the foot, assume it to be foot. So this is the equinus deformity of the foot. Here, because of the weakness of dorsiflexors, there is foot drop. Now the posterior, if the tibialis posterior is good, if its power is good, then the muscle will be transferred onto the first cuneiform bone, so that with that muscle power there will be some dorsiflexion of the foot. Different names are there, different techniques are there, but that is beyond the scope of discussion at present. So like that, a muscle which has good power will be substituted in place of a paralyzed muscle to restore the lost function. So that is one thing which is done. Tendon transfers and other things are done. One thing. And then for the correction of deformities, as we have discussed earlier, there will be some flexion deformity at the hip, flexion deformity at the knee joint and other things. Suppose there assume flexion deformity at the knee joint, there will be posterior capsular contracture and hamstring tightness will be there. So hamstring release and posterior capsulotomy are some of the procedures which are done. And suppose there is something like a genorecurvatum deformity, that is hyperextension at the knee joint. For your better understanding, I am telling that. Then there will be a wedge of bone will be removed and the axis is maintained. Such osteotomies, I will show you the picture in the upcoming slides. So such deformity corrections are also done. And sometimes when all the group of muscles are paralyzed, the joint will be flailed. It will not hold itself in a position. In such cases, the joint should be stabilized in a functional position. So that stabilization of the joint will be done. And coming, as we have also discussed, one more challenge is shortening of the limb will be present. So in that cases, equalization of limb length should be done. Otherwise, there will be gait disturbances, and with gait disturbances, spinal problems will also occur. So equalization of limb length should be done. If it is minimal, with shoe raise, the 2 to 3 centimeters discrepancy can be managed. However, if the discrepancy is more, we may have to go for epiphysiodesis of the contralateral limb. That is, you will either prevent the growth of the other limb, or some other limb lengthening procedures will be done to the affected limb. That all depends on the age, and different parameters are considered. So based on that, equalization of the limb length is done. So these are all the principles of surgical management. So this is the Hubbard bath which I have shown. This is warm water, and there the physiotherapist or nurse is assisting in passive range of motion of child. So here, coming to different deformities. In the hip, the most common deformity is flexion, abduction and external rotation deformity. So for that, there are multiple number of procedures, but for UG undergraduate level, these two procedures are mentioned. Whenever you have this post-polio residual paralysis as an essay question, you can write the definition, then the challenges, then the preliminary management, and then coming to the surgical management, these things you will write. In hip, you will have the flexion, abduction, and external rotation deformities. Usually, the flexors of the hip, iliotibial band, all these things are contracted. So, these contracted structures are released. That is the basic concept in all the deformity correction surgeries of poliomyelitis. So, two surgeries are given in your textbook: Sauter's release and Yon's procedure. In Sauter's procedure, you have the flexors of the hip stripped subperiosteally, and then the hip is immobilized in POP hip spica in hyperextended and adducted position for 2 to 3 weeks. In Yon's procedure, three tendons, iliopsoas tendon to prevent the flexion of the hip, and tensor fascia lata and gluteus medius muscles, they are also released. Here you can see the sartorius, gluteus medius, iliopsoas. Here you can see iliopsoas tendon is cut, and then the sartorius is released, gluteus medius and tensor fascia muscle, all these things are released. So this is the Oberjon's procedure. So these are the typical contractures which are seen in poliomyelitis. Here you have the flexion abduction contracture at the hip joint, and there is a flexion contracture at the knee joint, and valgus deformity of the knee. This valgus deformity of the knee is because of the contracture of tensor fascia, ITB contractures. You will have this iliotibial band contracture and tensor fascia contractures. You have the abduction deformity and valgus deformity of the knee joint. And because of this muscular imbalance also, you will have the varus and different cavus deformity of the foot, equinus deformity at the ankle joint. All these deformities are seen. Suppose the patient is moving on knee joint, there will be calluses present on the knee. So these are all typical contractures which are seen in polio. And coming to the knee flexion deformities, you have the hamstring lengthening and posterior capsulotomy. And in ankle, there will be contracture of the tendo-Achilles, which leads to the equinus contracture, which can be relieved by TA lengthening. And foot, there will be cavus contract deformity, for which you have the Steinler's release, where longitudinal plantar ligament and short plantar muscles are released to relieve the cavus deformity. So these are all few surgeries which are done to relieve the deformities of poliomyelitis. So here, And regarding the stabilization of muscle, stabilization of flail joints, you have a procedure called orthodesis, where you will fuse the joint in a stable and functional position. That is orthodesis. You have for muscle imbalance, you have tendon transfers, and for deformities, you have the different release procedures. For flail joints, you will go for orthodesis, and for fixed deformities also, you have certain fixed deformities means the deformed position cannot be brought back to neutral position. That is fixed deformity. There some osteotomies will be done. And for shortening of the limb, epiphysiodesis, heel rise epiphysiodesis of the contralateral limb, or some limb lengthening procedures, all these things will be done. These are the four things, and for these four things, these are the different surgeries we are going to do. And that serial charting of muscle power is important, because when we transfer one muscle from its original location to another location, it will lose its power by 1 grade. So I'm about to complete this poliomyelitis. So can someone tell what an MRC grading is? Muscle power. So I'll tell quickly. 0, there will be no contraction, and 1, there will be flicker of contraction, and grade 2, with gravity eliminated, there will be movement, and then 3, there will be movement against the gravity. 4, normal movement against gravity and resistance will be there, and 5, it is full power. So this is the MRC grading. So based on this, the muscle power is calculated. And then now in this picture, can you tell what gait it is? Can somebody tell from which movie it is taken? Here the patient is keeping, the person is keeping her hand on the knee joint. What is the name of the gait shown in the picture? Somebody? Somebody please reply what gait it is. Okay, right. So can you tell me from which movie that picture is taken? At least you know that, or you don't know? Some message, please. So basically, it is hand to knee gait, which is seen in poliomyelitis, because the patient, they will try to push the knee back to prevent the buckling of the knee. Because of the quadriceps weakness, this type of gait is seen. So for your interest, this movie is taken from Ganga, Nitya Menon's picture, is the heroine. And then the second gate here, which I am pointing it out with the cursor. Can you tell what gate it is? The muzzle is also depicted in the picture. This gate, name of the gate goes after that muzzle. Only one person is answering. So the gate shown in the first two pictures is the hand to knee gate, and this is the gluteus maximus flexure, gluteus maximus gate. So to balance the center of gravity, because of the paralysis of the gluteus maximus, weakness of gluteus maximus, the patient will sway back while moving forward. will move the trunk backwards. That is the gluteus maximus lurch or gluteus maximus gait. These are seen in poliomyelitis because of the weakness of the muscles. So this is all about poliomyelitis. So am I clear so far? So if I'm clear, we'll go ahead with cerebral palsy. Thank you for replying. Uh, then now we are going to discuss about another disorder, cerebral palsy. Cerebral palsy or Little's disease is a non-progressive neurological disorder of children affecting the locomotor system. Usually different etiological factors are either prenatal, natal or postnatal. Coming to the prenatal, there are different factors like genetic factors, prematurity and maternal infections like torches. So coming to the natal, during the labor, there will be difficult cerebral anorexia due to difficult labor or birth trauma, and post-birth some infections like encephalitis, which cause brain damage. All these things may lead to cerebral palsy. Usually, the child will be of age about 1 to 4 years. Will present to the doctor to an orthopedician, though it is dealt by pediatricians. Coming to the orthopedician's role in it, a child is brought to you approximately 1 to 4 years of age with history of delayed milestones or patient not walking and some motor problems. These are the symptoms with which the child is usually brought to us. So coming to the classification, there are two types. First thing, depending upon the type of involvement, you have the spastic, cathetoid, ataxic, rigid, and mixed types. In spastic type, it is the most common type where there is damage to the cerebral cortex. So there will be, as cerebral cortex is involved, there will be increased muscle tone and exacerbated reflexes. It is based on the part of the brain affected. In athetoid type, you have the basal ganglia involvement and there will be involuntary movements of the hands and legs. In ataxic type, you have the cerebellar involvement and there will be ataxic gait. In rigid type, the muscles are in constant state of contraction, and mixed type has features of spastic, ataxic and athetotic types. So these are the types. This is one classification based on the area of the brain involved. And the second classification is based on the limbs which are involved. First thing is quadriplegia, where all four limbs are involved. And the second type is diplegia, where you can see that lower extremities are more severely involved than the upper extremities. And coming to the hemiplegia, one side of body is involved and the upper limb is more severely involved. Coming to the triplegia, three limbs are involved. In monoplegia, only one limb is involved. So this is the classification. And there is one more classification based on the motor function, the activities of the child. This is called gross motor and functional classification system. In this, a level 1 child, he will be able to ambulate normally, but there will be decreased speed and coordination. And in second level, the child can walk indoors without aids and with some assistive devices like walkers, crutches, etc. And level 3, both indoor and outdoor mobility. Here you can see the child is using some assisting device for the mobility. Crutches, walkers or orthotics are used by the child. And in level 4, the child is wheelchair bound for mobility. But in the type 5, the child will not have independent mobility and the child will also not be able to maintain the trunk in upright position. So these are all the different gross motor and functional classification system. So coming to the clinical features, as I told earlier, child will be usually of 1 to 4 years of age with history of delayed milestone. And then the symptoms, severity of symptoms may be mild to severe. In mild cases, the child will be ambulant without support and they are detected usually by the spasticity of the limbs. While walking, there will be adductor spasm or scissoring gait will be present, and adductor spasm at the hip joint. So when there is passive abduction, there will be resistance at the hip joint, and there will be equine spasm of the feet. So there will be resistance to the dorsiflexion of the feet. So coming to different deformities and other clinical features, coming to the lower limbs, the hips are held in adduction because of the adductor spasm, flexion at the knee joints, and equinus deformity at the ankle joint. And because of the imbalance in the muscle pull, there will be deformities of the femoral neck, valgus angulation at the femoral neck, which I am going to show in the subsequent slides. And there will be external tibial torsion, that is, the tibia will be rotated outside. And scoliosis, as I told earlier in the polio, because of excess pull of one muscle and paralysis of the other side of the paraspinal muscles, there will be scoliosis, and hip subluxation will also be there because of improper muscle pull. So these are the conditions which are different deformities we come across in lower limb. In upper limb, we have the adduction, internal rotation at the shoulder joint. Elbow will be held in flexion, forearm in pronation, and wrist will be in flexion deformity. And most common deformity is thumb is drawn into the palm, and fingers are flexed at the MCP joint. So these are all the different deformities which are seen in upper limb and lower limb. And coming to the clinical features, most common type is spastic type. So we'll have exaggerated knee and ankle jerks. There will be patellar and ankle clonus also, and plantar response will also be extensor. So these are the different clinical features. So here you can see in the first picture, there is scissoring gait and adductor spasm of the muscles. One limb is almost obstructing the other limb while walking. So this is the scissoring gait and adductor spasm. So here the hip joint in cerebral palsy. See the neck shaft angle. Sure. So this is the neck and this is the shaft. The neck shaft angle, which should be around 120 degrees like that, is increased. The neck shaft angle is increased. It is more than 150 degrees like that. So increase in neck shaft angle is called coxa valga, and decrease in the neck shaft angle is called coxa vara. Second one I am just telling for your understanding. There is both the X-rays, they are showing coxa valga only, both the hips here. And this is the paralytic hip dislocation. See, the upper part of the femur is not present in the acetabular pocket. Here it is not present. The formation of head is also affected because whenever there is something called plasticity, biological plasticity between the femoral head and the acetabulum. So unless the proximal part of the femur is present in the acetabulum, that molding and correct shape of the femoral head is not obtained. So the femoral head is also not formed, and the hip is subluxated. It has dislocated up. So these are the different features. So coming to the management. Here our aim of treatment is to achieve the maximum functional ability and the skill that child can acquire. So by correcting certain deformities, here the aim is, suppose the child is intellectually normal and there are few deformities, with physiotherapy and exercises, those deformities should be corrected and the child should be educated. Suppose the IQ is not good, you cannot make them educable, at least the child should be trainable to do some sort of vocation on his own. That is the rehabilitation. In severe cases, even the child is so retarded that he can even not do some mechanical activities, then they must be trained at least to take care of themselves. So these are the aims. These are our aims to treat the patient with cerebral palsy. So our side of treatment is to correct the deformities, to prevent the occurrence of fresh deformities. That is the main role of orthopedician here. So to treat the muscle spasms, different treatments like Botox injections, backloaf and skeletal muscle relaxants are given. Rehabilitation of the patient is done. and some special education, repetitive activities of muscles and other things are advocated. Mainly physiotherapy is the mainstay of treatment to prevent the occurrences of deformities, flexion contractures, etc. So coming to the surgical management. So main aim of surgical management, just as we have seen in poliomyelitis, is to correct the deformities and stabilize the joints. Usually it is done between age of 4 to 8 years. And commonly done procedures are tendon lengthening. Suppose there is equinus contracture. By lengthening the tendoachilles, you will prevent the equinus contracture at the ankle. Suppose there is some flexion deformity of the knee joint, then hamstrings will be lengthened. Like that, lengthening procedures will be done. Tenotomy is also done. And tendon transfer operations, like I have explained before. Here in this, for example, transfer of pronator teres to from forearm to the wrist extensors. Here we have seen that in upper limb cerebral palsy, you have the most common deformity encountered is flexion at the wrist joint, pronation of the forearm, and flexion at the elbow joint. Suppose the pronator teres is released. This pronation deformity is prevented, is corrected. And by transferring that pronator teres to the wrist extensors, this flexion deformity will also be corrected, because since it is working, there will be some extension at the hip joint, wrist joint. So that is the one of the examples. So whenever transfers are done, first thing to maintain, since the muscle power will be decreased, so proper exercises before transfer and after transfer to train the muscle for its altered action, extensive physiotherapy is required. And the other thing is obturator neurectomy. There will be adduction contracture at the hip joint. So to relieve the adductor spasm, the obturator nerve supplied to the adductor group of muscles will be removed, ablated. So that is the obturator neurectomy is done. And whenever there are some flail joints, the joints should be stabilized by orthodesis. So these are the different treatments which are done. And these procedures which are done to correct the position of thumb and deformities of palm, just remember the names, that is sufficient. Matev's procedure is one procedure which is done. And then flexor pollicis longus tendon lengthening is done to prevent the flexion contracture, and other contractures also, the thenar muscle release is done. So these are all the different surgical management, commanded surgical management. So this is all about cerebral palsy and polio in brief. These topics basically uh, they're just mentioned, and very few questions come in your exams. All these things are dealt to you extensively, are dealt to you for your understanding. So I hope I am clear so far and you have understood. So this is all about poliomyelitis and cerebral palsy. I'm typing my email ID in the chat box. So if you have any queries, you can mail that your queries to my email ID. Thank you.